The Community Memorial Health System Speaker Series Online is brought to you by Mission Home Health. Mission Home Health and Hospice is committed to taking care of people by providing the highest quality, cost-effective care wherever the patient calls home. With over 14 locations, Mission delivers skilled home health, hospice, and palliative care services to more than 3,000 patients a day. As a preferred partner with several health systems, Mission works with providers to customize each partnership to provide exceptional coordinated care. Visit our website to learn more at www.homewithmission.com. We take care of people, and one call does it all.
Good evening. My name's Dr. Sam Small, and I want to welcome you to tonight's CMHS Speaker Series. Tonight's presentation will be on academic medicine. I'd like to start a little bit about myself. I have a rather checkered past. My first career in medicine, I was trained in family medicine, and I practiced family medicine in Ojai for 11 years. Long about the 9th year, I had a midlife crisis, and I went back into training for 6 years, first to complete an orthopedic surgery residency, and then a fellowship in spine surgery at UCLA. During my fellowship, there were a lot of teaching responsibilities for me to teach not only orthopedic surgery residents, but also medical students. And I was really bitten by the bug to teach. And I realized that the way I was taught could have been better. So when I got done with fellowship, I really wanted to stay in academic medicine, but I also wanted to return to Ventura County because that's home. And so I moved back here to Ventura with the idea that we could start having graduate medical education programs here at Community Memorial Hospital. The reason that occurred to me is we have an unbelievably talented medical staff, particularly for a 242-bed community hospital. Part of it is where we are located in beautiful Ventura, and excellent physicians, many of whom had taught at tertiary centers, just wanted to live here. So you'll see on the screen there that the idea for this, for me at least, started in 1997, which is when I moved back to Ventura. It got stalled along the way, and it was reborn about 10 years later in 2007. In 2008, it just so happened that I was chief of staff, and at the end of a meeting after I adjourned it, I asked if anybody that was interested in residency training programs would stay after. Everybody, just about everybody, sat back down, and I was peppered with questions, most of them pretty negative about having training programs here at CMH. But after the meeting, between 8 and 12 people did stay after who were very interested. They were I called them the non-stone throwers. So that, out of that group, 8 to 12 of us met every Friday morning for about an hour and a half to 2 hours for almost 2 years. And those meetings were to plan, to complete applications for residency programs, to recruit faculty, and to just figure out exactly what we wanted to do. So we were accredited for family medicine, internal medicine, and orthopedic surgery in 2012, but we didn't want to start the residencies yet because it was a little late in the year to start doing that. So to get our feet wet, we took 19 third-year medical students from Western University of Health Sciences. And as it turned out, that was very, very difficult because there were only about 10 or 12 of us teaching in those three specialties. And we didn't realize or think about the fact that without residents, teaching medical students is pretty tough. So in 2013, we welcomed our first class of interns. We had 10 interns in 3 residencies. four interns in family medicine, 4 in internal medicine, and 2 in orthopedic surgery. And then that was a little bit easier, but we cut down on the number of medical students to 8. And things got a little bit better after that, because the more residents you have to teach younger residents, the better. So that is our first class you'll see on the screen. And that little card is about the size of a business card, maybe a little bit bigger. So there weren't many. In 2014, we added general surgery. And then the ACGME, which is the accreditation agency in the United States. The secondary one was the AOA, which we were under originally, but those two entities merged between 2015 and 2020, and every program in the United States had to be ACGME accredited. So we had initial accreditation in all programs. It takes 2 years after that to apply for continued accreditation, and I'm happy to say that we have continued accreditation in all 4 of our sort of original programs: family medicine, internal medicine, general surgery, and orthopedic surgery. And we just got our continued accreditation in psychiatry. So we're on our way. As opposed to taking 10 interns in 2013. This year, the 2022-23 academic year, we have 29 new interns, 2 transfers from other programs, and now have a total of 92 residents here at CMHS in 5 ACGME accredited programs. And we also have a postdoctoral fellowship in psychology. We also have 44 third-year medical students from Western University. They're going to start here in about a week and a half. So it's a busy, busy time of year for us. We just had our 4 graduations. And I do want to talk to you a little bit about what is GME. So medical education is really a continuum. And it starts with undergraduate school. 4 years of undergraduate school, less if you graduate early. You have to have a bachelor's degree in anything, but you also have to have a lot of science prerequisites. Organic chemistry comes to mind. There are many others. And it is very competitive to get into medical school. You need a grade point average of over 3.5 and a medical college aptitude test scores of 30 or more in most cases. Next, after graduating from medical school, after undergrad is medical school. The first 2 years of medical school are basic science and lab. So it's classroom and laboratory, including anatomy labs, biochemistry labs, microbiology labs, and so on and so forth. The last 2.5 years are clinical rotations. And so when we take these 33 medical students from Western, we're taking them for their first year of clinical rotations. They have mandatory ones, things that you would come to mind: general surgery, internal medicine, pediatrics, obstetrics, and several more, and also elective rotations. Then comes graduate medical education after medical school. And in the United States, in almost every state, you need at least to complete 1 year of graduate medical education successfully, and then you can actually become licensed to become a physician. You're already a doctor when you graduate from medical school, but you can't practice until you've had a year of GME and finished your internship, essentially. That doesn't mean that people generally get out after that. Most everybody, 99%, stay in residency until they complete their residency so they can be eligible to take their certification boards and be board certified. Most hospitals, including CMH, require board certification to get on staff here. So you can see this poster of last year's incoming class, 21-22. We don't have this year's yet because they just got here, So there were 80 residents in there, so add 12, and you've got the picture of how many we have now. We are in the process of planning and applying for a pediatric residency, and there's a lot of interest in post-residency fellowships in our specialties. So that's something else that's a little bit different than standard graduate medical education, because you're already board eligible in a field, and then you go on and do between 1 and 3 or 4 years in some cases to become fellowship trained. The other thing the future holds for us is we're in the early stages of planning an integrated, comprehensive simulation facility here at CMHS. And simulation is not only the future of medicine, in many places it is the present in medicine. You've heard the adage, measure twice, cut once. Well, take that to about the 100th degree, because practicing on high quality and high definition mannequins for things like code blues, for intubations, for starting IVs and central lines, and many other procedures can be done on mannequins as well as on cadavers. And there are fabulous simulators that simulate laparoscopic surgery for general surgery as well as arthroscopic surgery for orthopedic surgery. It is extremely lifelike. And this cuts down on medical errors enormously in a hospital. So having simulation is not just something we want, it's something we really need. And we have some rudimentary plans. You'll be hearing more about that as we get further along in the process. The CMHS Foundation is excited about fundraising for us. It's not going to be inexpensive, but we already have some pledges, and we're pretty much on our way, and this will be a project much like GME was, in my opinion. So this is for everybody. You know, most simulation centers are either for nurses, for surgeons, or for other kinds of physicians. We want ours to be for not just for everybody, but we want to be integrated. We work together, and we work together very well here at CMH. There has traditionally been an excellent relationship between the medical staff and the nursing staff, as well as other allied health professionals. We want to keep that going, and we want to take that into the simulation environment so that we can get even better at teamwork. This will be a boon for our residents. This will be a boon for patients because patient safety improves. The rate of medical errors goes down significantly with simulation. Not just that, but to practice clinical skills, practical knowledge, maturity, experience, and teamwork, the one thing is because in today's environment, supervision is a big part of graduate medical education. In my era, many times we were not supervised enough, and that's a problem. The good news about a lack of supervision is you grow up faster, but simulation can fill in that gap easily, and that's what we're aiming for. So I think the future is bright for us here. There are some questions that have been, before I get there, I want to talk a little bit about, we do also, it's not technically a part of graduate medical education because it's not medical education, but we do have a postdoctoral program in psychology that has become very popular. I think that right now we have 2 postdocs, and a psychologist, even though they're a doctor and they have a degree, they're not even allowed to call themselves a psychologist until they're licensed in the state of California. And in order to take the licensing and certification exam, you must do a year of postdoctoral training. And we're very excited about that because that dovetails beautifully with our psychiatry residency, in which we're partnering with VCMC. And this is a huge thing for us because we really need psychiatrists locally. This is Dr. Doonan, and she came to us with all these ideas, and she's well trained. She's got a wealth of experience, and she has been absolutely great. She is in charge of our resident wellness program, which is extremely important. Residency is stressful, and our residents, we mandate they meet with Dr. Doonan twice a year. You might wonder, well, why is it mandatory? Because people with problems, emotional problems, they're usually the ones that don't seek help. This way, they have to spend a half hour in her office. If they want to read us a journal because they don't want to talk to her, they can do that. But believe me, they all do talk to her, and she has been really helpful. She has also pitched in during the pandemic for the entire institution because everybody is stressed out. There has been enormous stress, particularly on the nursing staff, and Dr. Doonan has been very helpful. She meets with the medical students as well, and she really has gone above and beyond the call of duty. So let's talk a little bit about the pandemic. We could not have met the demands of the pandemic without our resident workforce. Every single specialty pitched in. A lot of the burden fell on internal medicine and family medicine, but general surgery and orthopedic surgery residents pitched in as well, because a lot of elective cases, surgical cases, were canceled, and they did have some time on their hands. So we put them in the emergency department, we put them in the intensive care unit, we put them on the floors for extra help, because these are smart doctors. They're young, they're healthy, they're energetic, and we had this huge workforce that without that workforce, it would have been more burnout for our attending physicians, our medical staff, and we were very, very grateful to have residents. Medical students were helpful too, but in the early stages of the pandemic, the medical schools took their students out of clinical rotations for fear of them becoming infected with COVID-19. That has affected medical education across the board in the United States. The bigger institutions actually are more affected than we have been, but we find that over the last couple of years, sometimes when interns come in to us, they have all the knowledge, but they're not as comfortable talking to or examining patients. So we put them through some simulation already, but we're going to expand that program to get them up to speed faster. There have been some questions. I don't want to be redundant, so I want to just see what's on my next slide. So we also have teaching clinics. We didn't start with teaching clinics, but we now have teaching clinics in all 5 specialties. We have 2 locations in Ventura and 2 locations in Ojai. They have become very popular. These are academic clinics in as much as every patient is seen by a resident first, but the majority of them are also seen by an attending physician. I would say over 90%. The ones that aren't are generally seen by a senior resident who already knows that patient, but every patient case is presented to an attending physician. The case is discussed, the diagnosis is discussed, and the plan is discussed, and then they carry on and see that patient and recheck. So patients actually get more attention, and they get more attention in the hospital as well, because there are more eyes on that patient, and there are more eyes on the laboratory results and everything else. And again, there's questions about that I don't want to be redundant about. So, did we do these programs to meet physician shortages? The answer is yes. that was not my primary thought at the time. And it just so happens that we have training programs in areas where there are going to be the biggest shortages. Primary care, general and orthopedic surgery, and now particularly psychiatry. At this time, I would like to share with you some videos we have of our program directors and some residents that I think you'll find interesting. So I'll join you after that's done.
CMHS features 5 different residency programs, including family medicine, internal medicine, general surgery, orthopedic surgery, and psychiatry. Having different residencies at our institution fosters collaboration and makes for a diverse learning experience with exceptional didactics from leaders in many specialties. One of the things I enjoy the most at CMHS is the team atmosphere. We have a very supportive culture between residents and attendings that makes for an optimal learning environment. Residents feel well supported no matter what our career goals are, whether that is a focus in women's health, sports medicine, inpatient medicine, or preventative care. Having multiple residency programs on campus allows us to collaborate with our peers and develop into well-rounded physicians.
We strive to provide residents with experience across the full spectrum of care and allow them the flexibility to pursue their aspirations within the broad field of family medicine. We pride ourselves on our osteopathic foundation and have many opportunities to learn and implement osteopathic manipulative medicine into your practice.
We have 3 clinical sites. Community Memorial Hospital, our sponsoring institution, is a new 250-bed hospital with the latest inpatient care technology. Also on site are our pediatrics and OB-GYN experiences, as well as numerous subspecialty elective rotations. Ojai Valley Community Hospital is a 91-bed community-based acute care facility providing inpatient and outpatient care, emergency care, and skilled nursing services to the over 28,000 residents of the Ojai Valley. Our dedicated family medicine clinic, Midtown Medical Group, is located across the street from the hospital. We also see patients at 2 satellite clinics, one in Ventura and one in Ojai. Our new state-of-the-art hospital maintains aspects of a small community facility while retaining top-notch specialists due to our location and patient demographic. We have no shortage of interesting cases, procedures, and unique learning experiences.
Here at Community Memorial Hospital, our mission is to train outstanding physicians who work in a collaborative environment across specialties and give back to the community. And I think we have done a really good job in accomplishing this goal. One great example is our resident-run free clinic. Both family medicine and internal medicine residents work together to provide care to the underserved in our community. My hope for our graduating residents is that they enter the workforce as compassionate, clinically adept, and culturally sensitive internists. I want to instill them with habits of professionalism and lifelong learning. I want them to work collaboratively to improve our healthcare system, providing better, safer care. And most of all, I want them to be happy with their chosen profession, gaining fulfillment from their work. From what I have observed, we have helped our residents accomplish these goals. That is why we teach, and this is our reward.
Our educational program is robust and includes 5 hours of scheduled didactics each week, including a yearly 9-week cadaver anatomy course, annual boot camp where residents do ABOS skills modules, weekly fracture conference, and monthly M&M and specialty conferences. Wet and dry skills labs, including training on the Vertimed arthroscopic simulator, and regular journal clubs. We are very proud of our educational program. Our graduates have a 100% board pass rate. Our residents in training scores are excellent, and we have a 100% fellowship match.
We have partnered with major medical institutions to enhance the surgical education experiences. The pediatric surgical rotation takes place at Children's Hospital of Orange County, located in beautiful Southern California. And the surgical transplant experience is at the nationally recognized Cedars-Sinai Medical Center in Los Angeles. Our dedicated educational day is Friday. It consists of classroom work and hands-on lab. Early on in the academic year, we have a cadaver lab that is facilitated by faculty that help with the anatomical dissections. We sponsored an advanced trauma life support course, fundamentals of critical care support course, an ultrasound course with a certificate of competency on completion. You will also receive the fundamentals of endoscopic surgery and the fundamentals of laparoscopic surgery all throughout your training. The program now has an integrated 5-year robotics curriculum as well. The overall culture of the general surgery program is an environment of inclusivity. We also emphasize a progressive autonomy both in and out of the operating room. We have a 100% surgical board pass rate with a 100% fellowship match rate as well. We are very excited that you have an interest in the Community Memorial Surgical Residency Program.
Our residency is the result of sponsorship by Community Memorial Health System in close collaboration with the Ventura County Medical Center and Ventura County Behavioral Health. As we develop, we will continue to explore additional partnerships to provide the best training possible to our residents.
We also pay particular attention to the history of psychiatry and the effects of social determinants of health, stigma, and discrimination on mental health and its treatment. Because of the needs of our community, we give particular emphasis to training in consultation liaison psychiatry.
Due to our small size, we offer the advantage of rigorous training, close supervision, and mentorship, not only in training, but also in conducting research and career planning.
We're an excellent match for those looking for a community-focused residency who have a pioneering spirit and flexibility. The opportunity to achieve leadership and contribute to the culture of our program is a real benefit. One of the things that I love about the program is that it emphasizes from the first day that the resident is the primary psychiatrist for their patient, and that the resident takes ownership of the patient and proposes all aspects of the treatment plan to the attending, who helps guide the resident in improving the plan.
I could not be more proud of our program directors, associate program directors, faculty, graduates, or current residents. We do our best to specialize in smart, motivated, and above all else, caring physicians when selecting our residents. Welcome back. I hope you enjoyed that. I would like to take some time there's been some questions submitted, and I would like to take some time to address those questions. First question, what are the benefits of being treated at an academic medicine facility? There are actually many benefits. In the first place, there are fewer medical errors, and here especially, we have higher patient satisfaction scores. The reason for that is that the patients see more doctors because the residents see them and the attendings see them, sometimes together, sometimes separately. There are more eyes on their charts, there are more eyes on their laboratory results, x-ray results, scan results, and that's why things don't fall through the cracks. So, big advantage. Do we do research at CMH? The answer is most definitely yes. Currently, we have over 300 active research projects. We have over 50 publications in peer-reviewed journals, over 50 podium presentations at national and regional conferences, and over 50 poster exhibits at national conferences. These are all led by residents with attendings as well. We have a research team, and they have been very prolific, and for a hospital our size, we do a lot of research, and it's very valuable research. Do teaching hospitals have better outcomes? The answer is, since there are fewer medical errors, the answer is yes. Does somebody shadow the residents when they see patients, or do they see patients on their own? The answer to that is both, but for instance, in the first 6 months of internship or In many cases, we now just call it first 6 months of residency. The attending must see the patient. However, in our system, every hospitalized patient is not only seen by a resident, they are seen by the attending as well. So again, the patients get double, at least, the number of physicians that they're seeing. They are supervised, obviously. Initially, they're directly supervised, meaning the resident sees the patient with the attending, and then it depends on the resident. Some of them mature more quickly, and they're given the ability to see patients on their own. The attending will see them afterward. And so as they gain experience over the years, eventually they have to fly on their own. So in their last year, they're given a lot more responsibility, and particularly in their last 6 months, but only if they've earned it. Those that have not earned it or are behind, we have no problem having residents spend a longer period of time with us. And everybody, we have done that in the past, and every single one of them has really blossomed with the extra time, and they've been grateful for it. They fought us a little bit at the beginning, but after all, it is our decision. So what's the difference between a community-based teaching hospital and a university hospital? There's a pretty big difference. Interestingly, there are as many residency programs in the United States at community hospitals than there are at university hospitals. However, many more residents are trained at university hospitals because the residencies are bigger. The big advantage of being in a community-based hospital is residents get more hands-on experience. In a university hospital, residents are usually standing behind fellows, and they don't really get as much hands-on experience or maturity, in my opinion, and I've been trained at both kinds of places. So the Congress asked the Institute of Medicine to produce a report on the future of graduate medical education in the United States somewhere around 2012. And that was published around 2013 or 14. And one of the conclusions they came to is there need to be more training programs at community-based hospitals because university hospitals concentrate too much on research and not enough on training doctors to be doctors. What was the role of the medical residents during COVID-19 pandemic? I did address that during the talk, but I'd like to reiterate that everybody is grateful that we had them, administration and the Board of Trustees especially. Hopefully the nurses are happier too, but the poor nurses, they took the brunt of a lot and they're still taking the brunt of it. Last question, how was the overall program impacted during COVID-19? Well, again, we were very fortunate. A lot of the big programs, especially in the surgical specialties, residents have to have so many different kinds of operations under their belt before they can graduate and take their boards. Many university hospitals, those residents were behind in their numbers, and so they had the boards and the ACGME did make exceptions, but our residents, none of them were even close to not having enough numbers because they get so much experience that they usually have the numbers they need to graduate by the middle of their 4th year, and surgery programs are 5 years. So we have no trouble, but it did impact the education to the extent that they learned something that we never learned, which is how do you work in a crisis? So we learned together, but what better place to learn about a pandemic or something like that, a natural disaster, than to be in training with an attending physician standing or sitting right beside you. So all of our residents who have lived through that are now experts, and what I tell them is, hopefully this will be the last time in my career we see anything like this, but it probably will not be the last time in your career. So be thankful that you had the experience when you were with us. And I think we're all set now. I hope you enjoyed it. I hope it wasn't too boring. And farewell. It was a pleasure to be able to talk to you.